Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a right-sided ear infection, and you may have just noticed that when we entered the ear with the endoscope, we got a bit of condensation, a bit of fogging, and that's because of the increased temperature in the ear due to the ear infection. And buried within the infected debris was this hearing aid wax guard that the patient was completely unaware of, that had fell off and got lodged deep in her ear, but it wasn't visible initially because of all this dead skin, debris that's quite medially located. So when we say medial, we mean quite deep in the ear towards the eardrum. So when you've got an ear infection, it can obviously increase the temperature inside the ear, and that causes some humidity, and then because the tip of the endoscope at this stage, because we've just started the procedure, still a bit, it's not as warm as the rest of the ear, we get condensation at the tip of the suction probe. But as soon as we enter with the vacuum, the suction, it demists the endoscope almost immediately. The longer we're in the ear, though, the less misting we'll get. In any case, even without the vacuum, you can see the vacuum's not in the ear at the moment, and there's less fogging, and that's because the heat from the light source, which is illuminating the inside of the ear, it travels across the whole length of the endoscope. So the endoscope is a 5 centimeter steel tube, really, and it's lined with optical fibers which help to deliver the light from the light source, which is also forms the handle, into the ear. And so as the light's traveling across those optical fibers, the temperature of the lens and the endoscope itself slightly increases. An endoscope, what's great about an endoscope is that this heat is evenly dissipated, so it's never going to be too hot for the patient. So even if I was to rest the endoscope right up against the canal wall for about half an hour, the patient will not notice any increased heat, but it's just enough increase in heat so we don't get the condensation. So what I'm doing, I'm just using the fine end now, just trying to clear as much debris as possible. You can see the eardrum, although the obstruction has been cleared, the eardrum is not fully visible because we've got this crusted layer of dead skin, which I'm going to slowly peel away. Now, I'm pretty sure this patient has got a fungal infection. And the reason I say that is that this patient is on long-term systematics or oral antibiotics. And that's for a different health condition that they've got. So what's likely happened, it can happen secondary to use of antibiotics, is that unfortunately antibiotics can also stop healthy bacteria that live in the ear and which protect it from harmful fungi and other harmful bacteria from reproducing. So there's reduced healthy bacteria in the ear, which then allows an opportunity for harmful fungi to colonize the ear and start living on the skin that lines the ear canal. So the skin that lines the ear canal has its own ecosystem. We call it the skin flora, and it's made up of different viruses, bacteria and fungi. And through prolonged use of antibiotics, the healthy bacteria are no longer present, or they're not high enough numbers to almost fight away more harmful fungi. So the fungi can take its place. So it's not uncommon for someone to develop a secondary fungal infection after taking antibiotics. So you can see the skin is quite thick. It's almost like sticky tape, sellotape. I'm trying to avoid, if wherever possible, to use any drops, just because obviously there is a bit of otitis externa in here, but the skin was adhered and embedded against the eardrum. So I'm just going to use some sodium bicarbonate drops, just a little bit, just enough to loosen it. I'm going to avoid using olive oil if possible, because if it is a fungal infection, then it can exponentially grow in the presence of olive oil, because the fungi can feed off the olive oil. We have written to the patient's GP, we requested an ear swab just to confirm what type of infection they've got so they can get the appropriate medication. And in the meantime, I've advised them to use some over-the-counter acetic acid spray. So when you've got otitis externa, which is an umbrella term for an infection of the outer ear, the pH increases. Our ears are typically mildly acidic, between 5.4 and 7 on the pH scale. And if we were to take a pH analysis of this ear, it's very likely to be higher than that, possibly more alkaline. So the acidity in the ear helps to, again, fight away harmful bacteria and fungi. So by introducing acetic acid spray, essentially white vinegar, into the ear, it can reacidify the ear and try and fight away some of this harmful fungi or bacteria, whatever is going on in the ear. So you can see I've got most of the skin away. It's just here at the bottom, it's still tightly attached, and I think I'm going to use some drops in a minute. It's just enough to loosen it. I've not gone over the top with it. And it's going to really loosen the skin now. So this patient does wear a hearing aid. You would have seen that hearing aid wax filter that we removed. So we've advised them against using the hearing aid until this infection's completely resolved, just to help aerate the ear. If you've got an infected ear and you continue to wear your hearing aid, you run the risk of the infection never really going away. And people can also then develop stenosis, which is a narrowing of the ear canal. And that's typically caused through chronic and prolonged ear infection. So the ear canal, it becomes really inflamed, and it then becomes almost in a permanent state. The bone of the ear canal, it initiates the osteoblasts, which generate new bone formation, and you get a closing of the ear canal. So of course we want to avoid that. So the eardrum's fully visible, and all I want to do now is, as safely as possible, remove as much debris and dead skin as I can off the canal walls. Spoiler alert, there's going to be some left over, so please don't send me any emails and complaining about it. We still get one or two. So yeah, it's still a bit weird that people would find the time to email me to say that I've not done a good job. So where we are now, on the bony part of the ear canal in particular, it's very sensitive, and unless you've had an earwax problem or you've had someone poking around in your ears, you may not fully appreciate how delicate and sensitive the ear is. And I know firsthand, because I've had some trauma to my ear canal before, so I know how sensitive it is. I would compare it to if you've got a bit of a tooth infection and exposed nerve, and you drink something cold or you have an ice cream, that acute sharp pain, and it's horrendous. So first and foremost is the patient comfort. That's my primary objective. Then is to visualize the eardrum. So we get a lot of queries as to why we try and clear the center of the ear first. Sometimes when you can remove wax off the eardrum, for example, or from the center of the ear canal by working off the canal walls, but not always. Sometimes you can work on the canal walls, but it's just not going to remove the big boulder of wax. When we clean people's ears, it's different to washing a car. It's a different psyche completely. We're not trying to get every little last speck out. What we're trying to do is alleviate the patient's symptoms. So we want to help them hear and relieve any pressure. So quite often, the first thing I want to do, the patients come to be able to hear better. So we try and reveal the eardrum, and then afterwards, we work on the sides if it's appropriate and if it's warranted. But yes, of course, sometimes you can remove the blocked wax by peeling it off the canal wall. It just depends on the individual case. So in this case, we just wanted to, you can see I'm peeling all this stuff away, but it's not really coming away, or it is, but very tediously. So I've done my main job. The main job is to make this patient hear again. And now I'm going to try and just mop up as much as I can around the edge. So I'm just gently hovering over the floor of the ear canal. When you've got an ear infection, obviously the tissues are slightly swollen, so we get edema of the tissues, which makes them more sensitive. So if we were to abrase and cut this ear canal, it's going to cause a lot of trauma. So we've got to be really gentle. You can see I'm kind of angling the suction probe away from making direct contact with the canal wall. So I'm just gliding it across. And it's just a bit around the edge. And again, if we leave a little bit, I'm not too concerned. So we've got a great view. You can see the whole eardrum there. So the tissue, you can feel it. It's a bit soft and almost jelly-like. It's wobbling a little bit. And there's just a bit of debris at the floor of the ear canal here, and also on the front part of the ear canal. So that hearing aid wax filter, it could have been the patient didn't fully fit it. So they're replaceable. And what the wax filter does, it stops wax, because in most of our ears, we all have a bit of wax or dead skin, and it typically migrates out of the ear by itself, like a conveyor belt. So the ear is continuously recycling old earwax with new earwax in a conveyor belt motion. But when you wear a hearing aid, obviously, the wax and dead skin is being pushed further into the ear, and it can migrate into the hearing aid itself, into the internal electronics and circuitry. So at the tip of the hearing aid, there's a little wax filter, which is what I removed earlier, and it's got a gauze, and it traps the wax. That's another name given to a wax guard, or wax trap. So it prevents the wax from entering the inside of the hearing aid. But obviously when that wax trap is blocked, you're not able to hear, because sound can't come out the other way into the ear. It can't travel through the wax. So they're replaceable. If they ever get blocked, the patient themselves can change it. And for my clients, I change it for them every 6 months on their routine service and MOT of the hearing aid. And it could have been that this patient just didn't fully insert it, so as they're putting it in, it fell loose. Typically won't do any harm. It's the same size, more or less, as a grommet. So a grommet is an ear tube, a ventilation tube, which helps air to enter the middle ear in a case of glue ears. So if you've got middle ear fluid, or a blocked eustachian tube, so you've got a retraction of the eardrum. And grommets, the typical grommets, the Shah grommets as they're called in the UK, the white ones, they normally fall out of the ear within 6 to 12 months and slowly work its way out of the ear by itself. So I'm really pleased with that. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.